as well as in person. I will first introduce the panelists who are online. The first one is Parag Doshi from USA, Ramazan Zakir from USA, Parvez Miraj from USA, Nihat Kale from Turkey, Sungun Raha from Korea, Professor Kadria from Turkey, and Dr. Artan from Turkey. We have local panelists who are present with us: Professor Amber Malik, Professor Naveedullah, Dr. Sohail Khan, Atif Nazir, Asad Bukti, and Masood Ahmed. We will start the session. I would request Dr. Parag Doshi to speak on endovascular strategy for stumpless ostial iliac artery CTO.
So good morning, everyone. Hopefully you can hear me. And good morning to all the colleagues in Pakistan and the panel members. Now, this is a vast topic and I have a short, we have a 9-10 minute window. So try to create it not a case specific with some of my pointers on how I try to treat an iliac CTO. So what are the challenges of iliac occlusion? The stump may or may not be present. This typically involves a distal aorta also.
Can we see your slides?
Can you see it?
We can't see your slides, please.
Let me see. How about now?
Still we can't see your slides.
Okay. Let me see. Okay, let me try it again. I have sorry about that. Oh, 1 second. How about now? Do you have it?
No, we still don't have your slides. Now it's okay.
Yeah, now it came.
Okay. So sorry about that. So going back, the challenges of iliac occlusion, you may not have a stump. Number two, this is almost always involves distal aorta. The plaque is typically complex and it may have either heavy calcification, or sometimes you are stuck with a friable soft plaque with component of semi-organized clot. It also reconstitutes distal in a variable location. It may involve either external internal iliac bifurcation, or it may go all the way up to common femoral at the groin. And also, most importantly, it is in pelvic location and you don't have any muscles to tamponade a perforation, which unfortunately seems to be more common in this region. Some of my guiding principles in treating it: I start with the CT angiogram almost always to plan my procedure. I like to get multiple access points. Typically in a complex iliac CTO, I have a bifemoral and a brachial, occasionally a radial, but usually a brachial approach to accommodate larger sheath. I also have a principle: the subintimal access is okay, but I try to re-enter in the iliac or femoral as opposed to aorta. When you get it open, I do not attempt one-to-one balloon sizing. A little undersize is better than oversizing. And if it's calcified, we are frequently using shock wave to break up the calcium. I have a very low threshold for covered stent or aortic endograft. Treat it as if it's an aortic aneurysm. If the plaque is rather heavy, after crossing the lesion, I may require a surgeon to give me a cut down to prevent the distal embolization from the femoral sheath. And you always have to be prepared for rupture or perforation. Aortic occlusion balloon is always in the room. Coda balloon or one of those balloons and a large sheath is always available. What is my pre-procedure planning? The most important thing is to study the CT angiogram or digital subtraction imaging. I study the aorta as well as contralateral iliac. I also have figured out length of the CTO and diameter of the vessel. You look at the distal cap. Does it involve the internal iliac and external iliac bifurcation, or is it near the groin? The plaque morphology, whether it is calcium, whether it is soft or clot, and also collaterals, because I try to preserve the collaterals if possible. So you look at the 4 different aortic morphology that I just showed as an example. So the number one has really no branches. It's a long occlusion. I can go out, and even if I have a subintimal, I'm not in danger of losing anything. On the other hand, the second picture has a large collateral. If subintimal approach is okay, but I try to preserve these large collaterals in case if the procedure is not successful or even future if there is a restenosis. Now, the third picture in the CTA is more interesting. There is an internal iliac, but it is present through a collateral. So you have to be mindful of that. In the fourth picture, there is a tiny stump, or most importantly, there is a huge collateral as well as there is an internal iliac present. So in this case, I try to preserve both the collateral as well as internal iliac. So you have to have a little finesse in doing this type of procedure. The procedure steps, I start with a brachial approach and I place a 90 centimeter sheath in the distal aorta. Then I obtain access in the normal side and put a 23 centimeter bright tip or sheath, and I use that for road mapping for the occluded side also. And the last is obtaining access on the involved side from the femoral approach. If the occlusion is long and access is low, then I may actually stick the SFA or even a profunda and then use a stiff glide wire to again place a bright tip sheath. And then I obtain a high quality digital subtraction angiogram from all three access sites at the same time to create a live roadmap that will guide us in the procedure. What's the next step? So I start from the distal cap. I start from the femoral approach. I start with a short support catheter, either 45, 90 centimeter and a hydrophilic wire. If the distal cap is stiff, then I can use a stiff wire such as Confianza Pro or a Stato just to break the cap, and within a centimeter or two, I switch to hydrophilic wire, which may be either a V18 Command ES or Gladius, or it may even be 035 stiff glide wire. Once the wire starts progressing, if it does not progress fast, and I knuckle the wire, however, if the knuckle is wider, then I use a support catheter to manage it so I'm not creating a large subintimal space. If internal iliac is patent, it is important not to enter the subintimal space below it so that you can preserve the internal iliac. And just before the aorta, if it's a knuckle, then I straighten the wire. And as you can see in this case, if it's subintimal, I leave the wire there as opposed to try to re-enter in the aorta. And then by leaving this wire, now I have an access or effectively a live roadmap. Now, if the wire from below luckily crosses the aorta into lumen, then I finish the procedure after changing the wire for a 0.035. But if the wire has not crossed into true lumen into the aorta, which is not infrequent, then I leave the wire from below, and then I start from a brachial sheath. I take a 4 to 5 French 110 centimeter multipurpose or Berenstein catheter, and then I point towards the occluded iliac. The cap is most of the times hard because this has been present for a while. So I take a stiff 014 or 018 wire towards the occluded vessel, and I puncture the cap for a centimeter or two. And then within a centimeter or two, I change it to one of the hydrophilic wire using the wire from below as a marker. Now, what happens afterwards? If the wire from aorta happens to cross distally, then I externalize the wire either through the sheath or by snaring it, and then reverse the position by externalizing the wire and removing the brachial wire. If the wire from aorta is into subintimal space in iliac, then I go with either cart or reverse cart technique. And I call it reverse cart, but the time is not enough to describe the whole technique, but suffice to say that I inflate the balloon from the femoral approach and I re-enter in the iliac. Once again, the guiding principle is that the re-entry should happen in the iliac or femoral and not in the aorta to reduce the aortic trauma. And then occasionally we may use re-entry devices such as Outback or Pioneer if it's available. It's beyond the scope of the talk, but there are many unique cases that we have performed by puncturing directly into the inflated balloon using Outback or Pioneer. Once you have crossed the lesion, my preference is to perform the intervention from the groin and not from the brachial approach. Contralateral iliac sheath, which has been left in the aorta, is important as a roadmap and for angiograms. I start with a small balloon and then increase the size progressively. I'm constantly worried about perforation or rupture. For common iliac, I use balloon expandable stents. Covered stents are very frequently used for bulky lesions. And then I extend into the external iliac using self-expanding stents because this region is prone to stretching and bending. And I have had a couple of huge perforations when you think that the procedure over in post dilation of the stent. So I'm extremely careful in post dilation, and even a slight hypotension triggers a guiding angiogram once again to make sure that we're not leaking into the pelvis. And not infrequently, you may use kissing stents. Questions?
Any questions from the panelists?
Hi, Dr. Doshi. This is Amber Malik here in Lahore. Welcome to Pakistan Live. That was an excellent talk, very succinct. And I think very much the way we would do such a lesion, and with very basic, simple tools, essentially, but with good vascular access and good imaging and a pre-planned procedure. I think a couple of just remarks here that having covered stents all the time when we do iliacs is the way forward, because we have suffered and hypotension, and there is a very nice bladder sign that you see because you're continuously looking at the bladder at that time. And if there is a leak, you will see a dent in the, on the bladder immediately, and you know why the patient, if the patient has hypotension, you've got a leak essentially, most likely. And the next question was really, you said frequently we will use kissing stents in this. I would have thought that you are at the ostium and there is a significant lesion on the right iliac as well. So you would use kissing stents in this case. And also, how, even if there was a milder lesion, would you still stent it?
So it's a great question, and I'm sorry for running through the talk quickly. I think I had a little bit more time. So I actually have already planned out whether I'm going to use kissing stents or aortic endograft, depending on whether the patient has a lesion below the groin. If the patient has a superficial femoral artery lesions, then I know that this patient may need future interventions. So in those cases, I try to avoid kissing stents, and my preference is to use endologic stent graft for the which effectively aortic stent graft that does not lift the bifurcation. So endologic stent graft mimics the normal aortic pathology, aortic anatomy, and in future you can cross over and then do the other limb. So that's one. If the patient does not have significant disease below the groin, and I don't think, if I think that I don't have a reason to cross over later, then I very frequently extend the stents at least a centimeter, a couple of centimeters into the aorta. And that also depends on the distal aortic lesions. If the aorta is normal, and if the contralateral iliac had maybe just 20% lesion, then I do a stent on one side, and then I do balloon on the other side to prevent the plaque prolapse. To summarize, if there is an aortic lesion also, then I do kissing stents or aortic endograft. If the contralateral iliac is severe, I do kissing stents or aortic endograft as described. If the aorta is normal and the contralateral iliac has minimal disease, then I may protect the contralateral iliac by just a balloon inflation so that I'm not prolapsing the plaque.
Thanks very much.
Thank you very much, Dr. Doshi, for an excellent talk. Now we will move to our next talk, which will be given by Dr. Ramazan Zakir, and the talk is Best Approach for Failed Integrate Approach to the BTK CTO Transcollateral or Retrograde Intervention Route. Dr. Ramazan Zakir.